the BBMP has been the forefront for using innovative surveillance methods, such as wastewater surveillance, to track infection and take appropriate health measures. We will also be privileged to hear a keynote address from Dr. Anil Kumar, Principal Advisor, National Center for Disease Control, Union Ministry for Health and Family Welfare, who will provide us insight into the current state assessment of the surveillance system in India. And before I proceed, let me take a moment to thank our sponsor, JJ Biotech, Imperial Life Sciences, Huawei Life Sciences, Appendorf Private Limited, and BioEarth Supplier. We thank you for your support. We also will thank people as we go tomorrow into the last of the session on the kind of support that we have received from many that have made this workshop happen. We are immensely grateful for your presence this afternoon, as it's your collective expertise, insights, and dedication to improving global health that makes this workshop possible. Together, we will explore new horizons in surveillance and work towards building a healthier and more resilient world. Thank you for joining us on this important occasion, and let's embark on this journey of knowledge and sharing and collaboration to health systems. I wish all of us a very productive and enlightening workshop. I have the privilege of introducing and bringing on stage Dr. Rakesh Mishra, who's still with Trilokji, and we will wait for him to come before we ask him. And while we are waiting, let's invite the other speakers onto the dais. Dr. Krishna Reddy Nalamala, a practicing senior cardiologist and president of Access Health International. He's also president of INORDA, a health systems training institute, as an associate of Access Health. Dr. Reddy co-founded Care Hospital in 1997, a chain of tertiary healthcare hospitals located in 6 states across the country. He grew the chain across the country as the CEO from 2006 to 2013. In his illustrious career, he has founded many enterprises with a mission to evolve models of high-quality healthcare that are affordable and accessible. He co-founded Relisys Medical Devices in 1998 after realizing India's first coronary stent in collaboration with Dr. APJ Abdul Kalamji, then the chief of DRDO, in order to create an in-house platform for medical devices to make them affordable. Dr. Reddy has joined Access Health International as its country director in 2018 to lead the health system strengthening effort in the country and assume the role of the regional director Asia in 2021. In April 23, he assumed the role of President Asia. Indeed, a privilege to have you. Yeah, I have with us Dr. Anil Kumar, currently Principal Advisor at the National Center for Disease Control, NCDC, who offers extensive technical guidance to various divisions. He holds an MBBS and MD degrees in public health from Banaras Hindu University, India. He's further honed his expertise at the Johns Hopkins and Michigan University, USA. With 8 years of diverse experience, Dr. Kumar has contributed significantly to primary healthcare, epidemiology, international health, immunization, and leprosy. Throughout his career, Dr. Kumar has held key positions at prestigious institutions, including Additional General of Health Services, where he provided direction to the public health programs and institutes under the Ministry of Health and Family Welfare. At the National Center for Disease Control, Dr. Kumar led the epidemiology division and initiated Epidemic Intelligence Service, EIS program. He also served as the Incident Commander at the Strategic Health Operations Center, SHOC, at NCDC. During his tenure, the National Head of the National Leprosy Eradication Program, Dr. Kumar introduced transformative innovations that improved program indicators in India. Dr. Kumar's expertise has earned him the national and international recognition, evident in numerous accolades. He currently serves as president of the Indian Association of Epidemiologists and Association of Public Health Specialists in India. His scholarly contributions include numerous publications in prestigious and peer-reviewed journals. May I invite Dr. Anil to the table. Yeah. Privileged to introduce Dr. Rakesh Mishra, who received his master's and PhD degrees, Director of Tata Institute for Genetics and Society, who received his master's and PhD degrees from the University of Allahabad, India. He did his postdoctoral research at the Indian Institute of Science, India, University of Bordeaux, France, St. Louis University, USA, and University of Geneva, Switzerland. Beginning as a scientist at the CCNB, Center for Cellular and Molecular Biology, Hyderabad, he later became its director in 2016. His research interests are on comparative and functional genomics of non-coding DNA and many others. Currently, he is the director for Tata Institute for Genetics and Society in Bengaluru. In addition to his research accomplishments, Dr. Mishra is actively engaged in science, communication, and education, striving to bridge the gap between complex scientific concepts and the broader public. Dr. Mishra has over 3 decades of experience as a researcher and as an administrator, published more than 200 publications and several patents. He's also a part of the various committees as an expert member for CSIR, TBT, and various eminent institutes. May I request you, Rakesh? My privilege again to introduce Dr. K.V. Trilok Chandra, Special Commissioner Health, Bruhat Bengaluru Mahanagara Palike. Dr. K.V. Trilok Chandra, IAS, currently serves as the Special Commissioner of Health as well as the Zonal Commissioner for Mahadevapura Zone at the Bruhat Bengaluru Mahanagar Palike. He currently oversees BBMP's health department and has been instrumental in its implementation of public health initiatives, including the recent launch of the 108 Namma Clinic, head state of tele-ICU during COVID pandemic. In the past, he has essayed various roles, including District Magistrate Kolar, Commissioner Hubli Dharwad, Municipal Corporation Additional Commissioner, Urban Development Department at BBMP, and Commissioner, Government of Karnataka Health, Family Welfare, and Ayush Service. Dr. Chandra holds an MBBS degree and a master's degree in public policy. He was inducted into the Indian Administrative Service in 2007. Indeed, a privilege to have you here, Dr. Chandra. And I have the privilege of introducing and setting the session in the motion. So, may I request Dr. Mishra, please set the welcome address. Thank you.
Thank you, Ma, for introducing all of us and starting the very important and awaited event for some time. It's my pleasant duty to welcome all of you to this beautiful campus of Bangalore Life Science Cluster, which is located in the Agriculture University of Bengaluru. And this BLISC, what we call, has 4 institutions, including TIGS, which is Tata Institute for Genetics and Society. We have NCBS, which is a center of TIFR of Department of Atomic Energy. You are sitting in a building which is the Institute for Regenerative Medicine, Stem Cell. It's a DBT Autonomous Institute, and we have in the same campus Center for cellular and molecular platform, which is Section 8 company of IRAC for incubation. So we are really in a campus where science happens from all scales and from basic to all the way to handing over to the industrial partner. So it's a very unique campus, and in which TIGS is benefited by all these intellectual and facilities and resources that are around. At TIGS, we have very specific programs with the aim of letting or facilitating high-end science to solve societal problems. It's one-liner for us. So we work on three aspects: infectious diseases, rare genetic disorders, and crop improvements. Crop improvement work on youth genomic technologies to make climate resilient crops. Rare genetic disorders, we have initiated to work on very special way, is a very unique problem for us, where lots of patients go unattended and diagnosed. And the infectious disease, which is more relevant for today, we have surveillance and disease ecology, antimicrobial resistance, and vector control as our three main verticals. And surveillance has been in the forefront for past couple of years because of pandemic and so on. And this meeting, this workshop is really very relevant to discuss what we have learned and what we can share with each other, and how much we are going to use this experience before we forget the pains of pandemic. We should learn and make sure that this knowledge, this experience, and the learning that we have got, we share and help us in for general whatever public health problem are there, and also for potential pandemics in the future. I'm very thankful to all the dignitaries on the dais. Dr. Krishna Reddy has been really the inspiration and architect of this meeting, and so happy that he proposed that we can have it in this campus. Dr. Anil, Kumar, Dr. Chandra, I mean, for Bangalore, we have done really remarkable work on surveillance, and you will see in the first session. And I give a lot of credit and our indebtedness to Dr. Trilok Chandra, because his support would not have been possible. And that's the right occasion to thank him for all the writing he has done. I have experienced it in many cities, and Bangalore has been outstanding exclusively for that purpose. And then, of course, you need capacity and other things to do. So with that, I would like to again welcome all of you to this campus in TIGS on my behalf, on behalf of this campus, and behalf of my institute. And I look forward to listening to conversations, and hopefully we'll have lots of take-home message for our future. So thank you very much.
Thank you, Dr. Mishra. There is always a beginning or the first step that begins this journey. And to share where we started and set the context, I invite Dr. Krishna Reddy to ask you.
Thanks, Kumar. The dignitaries on the dais and participants, speakers, experts, scientists in the audience, and also participants who joined online, lest we forget them. The Global Learning Collaborative was launched last year, March 11th. March 11th happens to be the date COVID was declared as pandemic. It was launched with an objective to bring different stakeholders, both state stakeholders, non-state stakeholders, to discuss the issues that worked well during the pandemic, that did not work well during the pandemic, and also to build that culture of learning from each other, so that we don't forget what mistakes we made. In fact, as medical professionals, we have a weekly mortality meeting. what we did right and what we did wrong, so that the same mistake we don't commit to the next patient. So this is the objective, that the very act of discussion and the dialogue and the curiosity to learn should translate into some actionable insights, because ultimately the learning should translate into actionable insights. And some of those actionable insights, if they translate into a policy formulation or a strategic or a detailed planning to strengthen the gaps in the health systems, wherever the gaps are there. So that was the key objective of launching this collaborative, not only within the country, but across the countries, with membership currently hailing from almost 25 countries. And people drawn from different walks of life who are relevant to the health systems, whether it's policymakers, health system researchers, innovators, the private providers, civil society. Every stakeholder has their own perspective as to, and also every stakeholder has a solution to offer to this process. So that was the objective. And as part of this collaborative, the learning themes, I mean, it's like a streams of learning, starting with certain themes and then branching out into sub-themes and then converging back into actionable insights. And the thematic areas are structured around, to begin with, the people, their level of literacy, their awareness, their participation in governance, their engagement, their self-care, their self-solutions for the various health threats that they face. So that is the one theme. I mean, people who are interested in the theme around the people and the communities and their resilience to various threats. That becomes the learning journey around the people's component, because health systems, in effect, evolved to meet the requirements of the people, their health needs of the people, their health financing needs of the people. So unless we understand that perspective from the people, we may not be able to do that. Then the four core functions which meet the health needs of the people and health financing needs of the people is the provisioning of the healthcare services, supplying of healthcare goods, financing to access healthcare, the needed healthcare, and also financing to create the provider system to meet the requirements. And finally, the governance of a complex social system. I mean, the health system is the most complex social system. It involves illiterate health professional to the most literate health professional. No other social system is as complex as health system. And however, the governance becomes much more critical in how the health system actually shapes up. So these are the four core functions of the health system: provisioning, the supplying, the financing, and the governing function. So the themes, discussions, and the learning journeys are around these core functions and also some of the sub-functions. And there are three cross functions also we explored, which actually integrate this complex fragmented health system, because they are all interrelated and interconnected. And for any complex social system to be harmoniously working, there has to be these linkages in terms of the information flow across the system, the communication flow across the system, and the relationships at different levels, from the global level to the local level. And each of these resilience of the system with reference to the health threats were also discussed, being discussed around biological threats, the environmental threats, the geopolitical threats, the economic threats. That means the response of this health system will be varying from a threat to threat. Is the health system actually prepared to each of these threats? I mean, we have the example, live examples just around us. What's happening in Pakistan, or what's happening in Sri Lanka, or what's happening in Ukraine, or what's happening with the climate change across the world. It's a live example. So I think that we don't have to hypothesize that these threats are going to be in the future. So a good system is actually learning from all these things and is preparing the system for, I mean, that is exactly the definition of resilience. That are you able to prepare and respond and absorb a health shock and recover much faster and build back into a better system. I mean, if you just go back to the old fragmented and fragile system, then you haven't learned. So that's the basic objective of this learning collaborative. And taking the governing function, one of the critical aspects of the governing function is the monitoring of the system, the monitoring of the health status of the people. And this monitoring comes from the surveillance, the health surveys, the population level health surveys, and the various policy-related health research. But all these elements of the surveys, the surveillance data, as well as the health policy research data, how this monitoring and evaluation is being utilized to inform policies, inform strategies, inform actions. If this connect is not there between the monitoring and evaluation or study and analysis, that leads to the planning in terms of the policy, strategy, and other things. So that's why the disease surveillance as a sub-theme of governing function, of the sub-theme of overall health system functions. So that's how we try to link the journey of each thematic area. So this surveillance is taken up for that reason. And the course of workshop is organized in a way that starting with Dr. Anil Kumar's discourse on where we are today, basically where India is today in terms of the surveillance system, because that brings out what are our strengths, what are our weaknesses. Are these weaknesses can be surmounted by some of the innovative technologies, whether it's a digital technology or the molecular technology, because some of the gaps cannot be surmounted without integrating some of these innovative technologies. For example, the public health professional who cannot analyze the data, surveillance data, if he cannot analyze and interpret the data, he cannot act, he or she cannot act on that. But if the technology can analyze the data and present it in a visualization form, that any public health professional, whether well-trained data scientist or not well-trained data scientist, at a visualization that they can interpret where is the spike, where is the signal, and whether this signal warrants that they act, they alert. So these are some of the potentialities of the innovative technologies. I mean, we have seen what happened during the COVID, of the role of genomics, the role of molecular tech, role of this tech in responding to the pandemic, unheard of the speed of vaccine development within 1 year. Both technology, but more importantly, the social collaboration that happened across the world. So these are the two elements of, it's not just technology alone can do that. So these are the elements which will be followed by the session, I think today itself, on the role of the genomics, the molecular tech, with specific emphasis on the wastewater surveillance as a classic example, how you can put some of these modern technologies for the surveillance, and should they become the norm of the future surveillance system? What are the pros? What are the cons? Does the country have the capacity to do that? Does the country have the finances to do that? Because it's not just enough to say that there is a potential, but is it possible to integrate into the system? I mean, that is the part of the discussion in the next session. Then the session tomorrow, I think, will be following on what the potential of the digital technologies. I mean, which gaps the digital technology can fill in. I mean, we are talking of One Health. I mean, whether all this layering, I think in the lunchtime also we were discussing how to layer all this information from the environmental signals, from the veterinary signals, from the human signals. Can you do a precision public health using these signals? And which human beings cannot do it? I mean, you need the AI tools or the machine learning tools to do that. And already people are doing that. In fact, by layering all these things into a single visualization, that where there is a potential for heat-related events, where there is a potential for the mosquito vector can flare up because of the temperature changes that are shifting because of the climate change. So these are, I think, some of the applications in the digital technology that can be discussed in the next tomorrow's first session. That will be followed by, again, another emerging topic of the surveillance in terms of the One Health concept. That means the humans are not in isolation. They are interrelated, integrated with animals, with plants, with the planet health. We are not separate. So unless we take care of the planet, unless we take care of the animals, unless we take care of the plants, we are not healthy. But how to integrate the indicators from all these layers into a single thing, I think that is the One Health concept which is going to be discussed. And all these insights will be concluded in the last session in terms of what insights can be brought into the policy. So, because ultimately these insights have to be actioned and translated into policy, because only the policies and strategies can make a national level impact or the global level impact. So these are, I think, some of the thought process behind sequencing these sessions in this workshop. We hope that there will going to be a rich discussion in the halls and outside the halls during this beautiful campus. I think you can enjoy discussing strolling in the campus. With these few words, I thank everyone. I thank Rakesh for this special. We feel that academic atmosphere here. So that's the starting point for the learning. Thanks, Rakesh, again for this hospitality and the hosting of this. Over to you.
Thank you, Dr. Reddy. 08 number clinics and somebody who has implemented that. So somebody who has the larger public at heart. I request Dr. K.V. Trilokchandra to please come up and share his inaugural address. Thank you.
Hello, namaskara, good afternoon, everyone. It's indeed my proud privilege to be amongst all of you today as part of this very important and oft forgotten lessons of the pandemic, that we need to keep up our vigilance against emerging threats. I think probably it's part of our human evolution psychology that we tend to forget painful things very fast. So it's part of our survival strategy, I guess, but not a very useful thing. So it's very important that we don't forget the lessons of the pandemic, and particularly the importance of primary and primordial interventions as part of the surveillance cannot be overstated. Sentinel sites to pick up emerging threats need to be kept primed always. So I think sessions such as these should be the norm to keep up our vigilance. So we continue to remind ourselves as to what went wrong and what has to be done to ensure that we don't end up doing the same mistakes as what we did or what led to the very painful pandemic. So as part of our public health strategy, we are in the process of setting up our metropolitan surveillance unit in the BBMP area. I think it's a very important step so that we have the state-of-the-art public health lab itself in the BBMP area. So we continue to test diseases and samples of public health importance, along with, of course, partners such as TIGS, NCBS, and others who have partnered with us during the pandemic. And I think environmental surveillance was a very important thing, which we had done along with TIGS and other partners who are here. So that gave us a very good heads up as to what are the emerging strains before even the clinical data was available with us, so that we continue our testing or focus our testing in particular areas or wards where it was maybe what you can call as subliminal infection rates which are there. So I think environmental surveillance is an important area where it holds a lot of promise. Sure, the newer areas where this is being focused on, particularly with respect to antimicrobial resistance, microbes and other areas. I think dengue is a very important thing, being our tropical area. We strangely have alternate years of peaks which keep coming. So despite being a freshwater breeding mosquito, people tend to neglect it, which causes a lot of unwanted morbidities. So I think that's just before coming here, visited a state-of-the-art insectary, which was part of this place. I think where cutting-edge research is happening. So I think we need to quickly scale up solutions which are of public health importance, where practical or proven solutions are quickly rolled out. so which actually people can absorb, and a lot of preventable diseases can be handled. And as part of One Health initiative, we have already set up a One Health cell in the BBMP with multiple subcommittees. Particular, and one of the major things is the technical One Health part, where we are partnering with some of the big players in the data field. The big data players are there to give us heads up on the emerging threats. So I think that is one area where the Sentinel sites and what are the key features which we need to focus on. We cannot expect the same kind of disease patterns to be coming. I think we need to be alive to other threats which might be coming our way. So I think the big data and the AI, I think, will play a major role in analyzing quickly the data which is coming, which may not even be perceptible in the first go. So I think that is one of the areas where we need to focus on. And I think we are on the path to have a very robust One Health cell in the BBMP itself. We are already partnered with the best brains in the business. So I'm sure we can come up with some meaningful solutions to the entire thing. So as part of the surveillance mechanism for which the current workshop is on, I think if you're able to come to put together a action plan or a workable action plan so that we can collaborate, both public health partners as well as research brains who are here, so as to what could be a SOP kind of a thing, where these are the things which we routinely need to do as part of our public health initiative. We have a large footprint of public health facilities which we continue to ramp it up. So which are the things, or in the form of a questionnaire or kind of basic toolkit which will be available to our healthcare professionals at the grassroots, which they can use on a day-to-day basis. So which are the key parameters they need to keep in mind so that we make our entire surveillance system very robust and nothing catches us off guard. So thank you for inviting me here and having me here, and I'm sure the workshop will lead to very fruitful results. So continue, love to continue the interaction and collaboration with you.
ನಮಗೂ ಚೂರ್ ಕನ್ನಡ ಬರುತ್ತೆ ಅಂತ ಹೇಳಕ್ಕೆ ಥ್ಯಾಂಕ್ ಯು ಹೇಳ್ಬಿಡ್ತೀನಿ, ಧನ್ಯವಾದ ಹೇಳ್ತೀನಿ. But when a doctor meets administration and policy can change, we just heard what can happen when you look at surveillance at one end and impact at the other. So dhanyawada, and we look forward to making sure that we have more of this come to you through Dr. Rakesh and through the Global Learning Collaborative. Of course, we keep coming back. Thank you. We now request Dr. Anil Kumar to give the keynote address on the current state of assessment of surveillance systems in India and the gaps that need attention to build back better surveillance systems. May I request you, Dr. Anil?
Dignitaries, experts, participants, both online and offline, friends. I would like to thank the organizer for, first of all, organizing this particularly important workshop here and inviting me. I think the surveillance is the most important area, and we most of the time, do not, do not understand the importance of surveillance. So I will be presenting, last 25 years journey of surveillance system in India. That is also important, and then I will be talking about what we can do to further improve it. So it's not that surveillance system was not there in India before 1997. 1997. Different, states, they were having their own surveillance system. I remember Tamil Nadu. They had comparatively good surveillance system. They were having, for most of the important communicable disease, they used to maintain line listing at a state level. That was quite impressive. But what led to starting the first surveillance system in India was two major outbreaks. First one was cholera outbreak in 1988, another one plague outbreak. Plague outbreak, there was lot of hue and cry everywhere. Many flights to India were cancelled. There was lots, huge economic loss to the country, and that led to government of India constituting many committees, and then they all recommended that we should have a surveillance system. So we had the first surveillance system in India, that is National Surveillance Program for Communicable Diseases. Not many people know about it. We started with 5 districts, and then we expanded to 101 districts everywhere in all the 35 states and UTs in the countries. You can see the map of India, where all we had these districts. So idea was to strengthen the surveillance system in the country, and also to strengthen the states and districts so that they can handle the outbreaks and investigate the outbreaks. Before that, most of the time, a team from NCDC was going to different places in the country to investigate the outbreak. And we also developed at that point of time, that was, more than 20 years back, a web-based reporting system where you analyze also. The data was analyzed on web portal only. So we developed at that point of time. And then we had World Bank support. So we brought the Integrated Disease Surveillance Project. The project was for a limited period of time. But the idea was that this will be integrated surveillance project, where we will have surveillance for communicable as well as non-communicable diseases. And the idea was that we detect outbreaks. So initially, there were a lot of discussion going on, lot of evaluation of idea was taking place. And it was, considered that to start with, we will detect outbreak and we will respond to outbreaks. So rapid response teams to be formed at the state and district level. And also, it was decided that we will bring IT support to the surveillance system. So that is how we move. And then at that point of time, 14 conditions were identified, and 5 conditions we left to the states to start. So 19 conditions were being under surveillance. These conditions were under surveillance, and there were 3 types of forms to be filled up: the syndromic S form, the presumptive P form, and from laboratory the L form. So these 3 types of forms were being filled at different level. But problem was these different forms were not not connected. Whatever is being reported in S form is not necessarily linked to the P form, and whatever is being reported in P form not necessarily linked to the L form. So you totally the analysis and interpretation was very limited. But we brought the communication technology with the support of NIC and ISRO, and many of you must be remembering that we were having all these state headquarters and district headquarters, and some medical college used to have that dish, and then we used we were supposed to connect to different districts and state through, video conferencing, analyze data, talk to districts. But somehow, we could not use that technology very effectively. And the reason was, and we should, learn from our past, that we brought technology, but our system was not ready to use that technology. And that we should understand, that whenever we are bringing the technology, system should be ready, whatever technology we bring. But we had IDSP portal where you can report, you can view reports. Then the laboratories were being supported. Initially, we thought that we will support laboratories at all levels, but later it was decided that support will be only for up to district level. Media scanning was another media scanning and verification center. Now this is a concept which we need to understand. Earlier days we used to think that if some information about a disease is coming through media and not through our system, then our system is failing. That was being considered earlier. But then it was realized that it will take some time for our system to reach at that particular level where our reporting will be first, and then report will come from media. So media scanning, center was formed, and all those, newspaper reports and all those, reports from other sources that were being screened, and then we try to detect the outbreaks and to start the response system. We also started 24/7 call center. You must all be knowing. And then at that point of time, as I said, that it was being considered that why not to have the non-communicable disease also. So we had, survey for non-communicable disease, but we could not, move further in that direction. Community surveillance is one concept. We started in some areas, some tribal areas, community surveillance, where community volunteers will be there and they will be reporting. It was a very good concept. Even NIE Chennai, they also did some work in this particular area. It's quite interesting, and I think this is something which we should always consider. Then came 2012 when NHM, the IDSP was under NHM. Objectives were more or less similar: to detect and to strengthen surveillance, to detect outbreak, to respond, to have the rapid response team and all that. And these are the disease. 36, right now we have these 36 disease and conditions to be reported under IDSP. I will not go into details of all that. And then now we have developed, and this is bringing technology to the surveillance, national surveillance, the integrated disease surveillance program. We have brought the integrated health information platform, and it gives us a lot of opportunities. And we have support of technology reaching everywhere at all the levels. So it is earlier it was weekly reporting. Now we have the real-time case-based information. We are using GIS system can you can utilize the data from by doing different type of analysis in different forms. Reports can be generated through platform, and we can bring information to this platform. We can bring information from various sources, use all that information for interpretation. And different standards, and then IDSP has standards which will be matching standards of different other information which is available in the country. So HMIS, IDSP, NMED, all those, they are only on this platform only. So it is easy to use data available from those different other surveillance mechanism which we have in our country. So ultimately, what we want to have all information, all health related information available on IHIP, bring all health related information from other sources also to this platform and analyze and interpret it. So these are some of the I think I already mentioned that earlier we used to have the aggregated data. So many cases. Now we have segregated separate data for each and every condition, and we can analyze separately. Now we have the linkage of SPL and EWS. EWS is the early warning signal form. It was paper based now. It was paper based earlier. Now it is electronic. It was weekly earlier. Now it is real time. Earlier 18 conditions. Now 33 conditions. And the information which we have is geo-coded, which is very, very important, very useful. So this is the IHIP platform. As you can see in the center, the square is there. So all this IDSP, VPD, and other HMS, everything is available on IHIP. We are linking it with ABHA also, so that we can use this information from ABHA. Whatever information is available on ABHA that can be used by IDSP. Private network and hospital, private labs, they are already providing information on the IHIP platform, but NICE hospital state applications still it will take some time, and we will start getting information from our sales also. So geometric probably state imagery, we can always bring that information, and LGD, local government directly. All that information we can bring to the platform, and we can analyze data. So this is where we stand now. So what to be done? As I said, that system needs to be matured. Still, we have system ingredients, technologies there, but the human being, the manpower, they all need to be oriented to this stage. And also the other system, the data available with other ministries. We need to work with them so that we can bring all that information to the platform, so that we can use that information effectively. See, we talk about many times. We talk about outbreak, early detection, and response, so that we can minimize the morbidity and mortality. This is what we talk about. We rarely talk about the prevention of outbreak. It is possible to prevent an outbreak, but nobody talk about prevention of outbreak. What is the reason? Reason is difficult to measure. In a district, if you have responded early in an outbreak, you can measure it. But if you have prevented outbreak, how you are going to measure it? This is one issue, and we have to find out how to do that. I think we need to develop indicators so that we can measure that. But this is area we should be collecting data, we should be responding data even before outbreak has occurred, so that we prevent the outbreak. This is something we need to discuss at various levels. Community-based surveillance. It was good initiative earlier taken, but right now it is not there in the program. So community-based surveillance means surveillance not only through the community volunteers, but also the Panchayat Raj system. Now they can be, we know Asha is very, she is busy. She has so many all programs, national programs. She is responsible for implementation. So we need support from the community. The Panchayat Raj system is one aspect, and I understand that this is one area where we can use resources. We have 600,000 villages all over the more than 600,000 villages in the country. We have Panchayat Raj system, and I was national program manager for the leprosy eradication program, and I use that resource very effectively. So I think we need to develop some sort of system by which it's developed in our habit at village level. So whatever is happening, they start reporting to the system. Data analysis and interpretation. Now most of the time, and presently what we do, the data analysis mainly at the most district level, state level, national level. but data should be analyzed at the lowest level also. I expect that even the multi-purpose worker, she should be in a position to analyze basic data. I'm talking about basic data, and it can be, have huge impact. The basic data means just basic indicators, even numbers going up, going down, all that. And the medical officer, primary health center level, and everybody, they should analyze, and they should act at local level. They should be in a position to deal with any abnormal increase in cases before we have an outbreak. An outbreak will start from one village only, probably, most of the time. So that, if you can control it there, you can prevent many outbreaks. So there is another issue. We have a lot of surveillance data, but how effectively we are analyzing this data? Do we do regression analysis? Do we do GIS-based analysis? GIS mapping at the most we do. There is a lot difference between GIS mapping and GIS-based analysis. We do not talk about GIS-based analysis. And how the economic data, how water supply data, how we are usually using that data to make an interpretation. We are not doing that. I think we need to work in that direction, and we need to train people. The problem is the training is one area. We need to train people in epidemiology. Now NCDC is already doing that, but I think we need to further enhance this training, and the states should take the responsibility of training the manpower in that particular state. Models, mathematical model is the new area. So we need to develop IT-based mathematical model. Now, mathematical model is new thing. Not many people talk about mathematical model. But the concept is, and as I understand and from my experience, and I work in that area also earlier, can we develop a model, IT-based model, which is available at district level with a district surveillance officer and other program officer? Can they feed the changes they want to make in their district? And can they plot how these changes are going to have an impact in terms of the output? And can we then take a decision, the evidence-based decision, that if we make these changes, this is the input which we are going to give, and what output we are going to get. If we can explain, we can explain to decision maker at district level, state level. I'm sure there a lot of resources can be provided to the district program manager, district program manager, and then things are easier. So that is required, and then you can take effective decisions at different level. The program is specific. The problem is we are having national programs. Having the national program is not a problem. The problem is we are not effectively implementing the national health program. Why we are not able to implement effectively? Because we do not have program-specific surveillance system. If we have program-specific, the problem in many of the national programs, if you want to compare one district with another district, one state with another state, you cannot. Because we do not have a good surveillance system, because data is not comparable. Data is not comparable over the period of time. Data is not comparable when you want to compare from one place to another place. These are the basics of a surveillance mechanism. You all know that. So unless we have good surveillance system in each and every program, we cannot effectively implement the program, and we cannot achieve what we want to achieve in the country. I have already practiced it. I was, as I said, I was national program manager for national education program. For 4 years, I had very good surveillance system in place for leprosy. And in 4 years' time, we could, because of the good surveillance mechanism where we had, we prevented some 30,000 disability due to leprosy. That is, a lot. Those who know disability due to leprosy, you have a lot of suffering. I have seen people, 13 years girl, if she is having disability, and you can understand the type of life she will lead. A person who is dying, suffering is over, but the person who are with, disability, also with, stigma, the suffering, so it was a lot. And all our indicators were all-time best. 60% of our cases are in India. So global data changed because of, a good surveillance system, and then, of course, the action based on that surveillance system. Molecular epidemiology. This is an area. I was talking about this molecular epidemiology. I started talking some 15 years back, but I could not bring it into the system. I was heading epidemiology division at NCDC. We brought INSACOG and all those things during pandemic. We should have done it much earlier, and we could have been very effective had we started it earlier. But in any case, now we are having it in the system. We need to expand it to various other areas, and that is going to be very important area we need to work. And I understand many of you are working in that particular field. Artificial intelligence in surveillance, of course, it is required, but artificial intelligence has limitations. Whatever best artificial intelligence system you have for anything, it will have limitations. Ultimately, our system, our people, our manpower should be ready to use this artificial intelligence also. That is, I think, many times, we are very fast in bringing the technology, but we are slow in making necessary changes in our system. I think that is one area we need to concentrate. So ultimately, the whole gamut of response in public health should be linked to the surveillance system. I think if we are able to achieve that, it's possible to achieve that. So I think if we are able to do that, we can be the best. I'm saying that India has opportunity. India has potential to be best in the world. And that time is over. Then when we used to compare ourselves with US or some other countries, I think we can do better than them, and we should stop comparing ourselves with those developed countries. So the conclusion is, we need to have a very good surveillance system if we want to take our healthcare delivery system to the highest level. We need to bring all health related data and all that information to one platform, and then we have to use the advanced public health tools and technique to analyze, interpret, and then take action. Action is very, very important, because we do everything, but we do not take action based on what we get. Thank you very much.
Panelists back on the stage, please. How many relevant and so important points that came through from you, Dr. Anil? People at the center, and that nothing can be more important than people at the center. You need capacity building. You need a mindset to change. You already have shown us what 25 years of surveillance has been, and the importance and need for it as it grows every day. Your work in leprosy and the way you have looked at surveillance in enabling disability, prevention of disability and relationships. Those people who are right there at the bottom of the pyramid, who face both stigma and disability. Surveillance has more than one area. Surveillance is more about prevention. How can we have things that we can use as indicators so that people are willing to prevent, not treat? I can go on. This list that you have and has set the tone for us for the next day and a half is going to be something that we will keep working on and keep reverting to. The importance of epidemiology is something that will also be noted and also be looked at as we go forward. It is indeed a privilege to have such an august gathering and such an eminent panel to begin what we are going to take forward over the next day and a half to see how we can build back better surveillance systems. While this session comes to an end, I have two announcements to make. One, that we will have a photograph outside on the steps from where you walked in from the canteen from lunch. And it will be a privilege to have all of you to be a part of that photograph. Two, may I request Dr. Farah to please come up to honor the guests of the stage today. So, can you please help us? Come, Namrata. And I will start with Dr. Trilok Chandra. You go up that side. It's an honor to have you with us this afternoon. Thank you very much. Farah, can we have Dr. Anil be? Thank you. And of course, our own, we don't want to let them go like that. So Dr. Rakesh Mishra, because you're the co-host. And Dr. Krishna. And can we all stand up here to have our photograph? Thank you. There's tea outside, and before the tea is the photograph on the steps. Right, okay? Following her PhD. Her research experience in disease ecology is drawn from studies on the phylogeography of avian malaria parasites in remote Pacific Islands, highly pathogenic avian influenza virus in Mongolia. As a recipient of the Welcome Trust TBT India Alliance Intermediate Fellowship, she established the research program, leading a team undertaking research on epidemiology of avian malaria and spread of diseases in high-altitude malaria-free zones in the face of climate change. Since 2019, Dr. joined the Tata Institute for Genetics and Society to lead the field of ecology and population genomics of key mosquito species involved in malaria and dengue transmission in India. In addition, during the peak COVID-19 time in 2021, in a multi-stakeholder partnership, she has established the wastewater-based epidemiology of SARS-CoV-2 and other infectious agents around Bengaluru. And this is when I have actually made her bio briefer, so I can actually go on. With this rich experience of infectious diseases, she's been a part of the following working groups on environmental surveillance and One Health, wastewater working research groups with Bill and Melinda Gates Foundation, executive group member, Public Health Environmental Surveillance Evolution Framework, PHESEF, co-lead on the One Health Consortium for Bengaluru City, Bengaluru Science and Technology Cluster, BEST, approved by the BSA Office, Government of India. The co-chair, India, AMR Innovation Hub on AMR in Environment and anchored by camp. Invite you, Dr. Farah. Please be on side. Privileged to have yet another luminary, Dr. Madhavi Joshi, a Joint Director, Gujarat Biotechnology Research Center. Dr. Madhavi Joshi's research interests are OMICS, omics technology, including genomics, megagenomics, and transcriptometrics, with the focus on One Health. She has 15 plus years of experience in research and in administration. She has published several scientific papers, book chapters, and in magazines along with patents. She's also an executive editor of the Biotechnology Chronicle, a quarterly magazine of the Gujarat State Biotechnology Mission, and has an eminent role in planning and coordinating the activities of the mission. Has developed web resources and is involved in connecting several courses for young investigators and students. Contribution to COVID research in the state of Gujarat is highly appreciated. Her group was the first to detect SARS-CoV-2 in wastewater in Gujarat. The sewage surveillance by GBRC has been carried out since the first wave of the pandemic in major cities of Gujarat using real-time PCR and digital PCR methods. They've also been sequencing the viral genome from wastewater to identify the variants. May I request you, Dr. Madhavi, please join us. Dr. Priya Nagaraj, the CEO, Pune Knowledge Cluster, and a dear friend. It works with the Pune Knowledge Cluster, PKC as it's called, which is a first of its kind initiative established by the Office of the Principal Scientific Advisor, Government of India. The PKC works as an enabler and a catalyst to create and nurture collaborative S&T ecosystems for various stakeholders, including industry, academia, government, and citizens. PKC works in the areas of health, sustainability, environment, mobility, and capacity building. During the pandemic, PKC built and managed a robust consortium of organizations, including R&D, hospitals, pathology labs, civic body offices for wastewater surveillance of COVID-19. This machinery and expertise is now being extended for surveillance in other infections. Priya comes with over 10 years of multi-organizational experience working in the pharma industry and the innovation ecosystems. She holds a PhD in biology from the University of Virginia, USA. Privileged, Priya, to have you here with us. Oh, right. Dr. Sundar Ganapati, Fellow, Office of the Principal Scientific Advisor, Government of India. Dr. Ganapati holds his PhD in pharmacology and is an MBA from Penn University, complemented by a master's in veterinary pharmacology from the Indian Veterinary Research Institute. His career as a biomedical researcher at the National Institute of Health, focusing on ion channel physiology and in situ phosphate biology. With prior roles as Deputy Director, Chief of Staff to the President of the Global Health Division, and Program Officer for the Gates Foundation, he has delved into some of the various aspects of health. Dr. Ganapati's work in the One Health sector, uniting animal and human health, is notable. His involvement in launching the Grand Challenges initiative to source the innovations demonstrate his dedication to addressing vital issues. He places emphasis on research and development, tackling concerns like preterm birth, eclampsia, and malnutrition. His contributions have funded innovations related to childhood, neurodevelopment, and creation of AI, ML-based solutions. Notably focused on revolutionizing healthcare, he's including the development of automated ultrasound for low-skilled healthcare workers, enhancing pregnancy and newborn monitoring expected mothers. Collaboration with prominent companies such as Google _ his commitment to innovative healthcare solutions. Currently, Dr. Ganapathy is actively collaborating with the Ministry of Animal Husbandry and Fisheries and establish the national digital and architecture for the livestock sector. Indeed, a privilege to have you here, Dr. Ganapathy. I'll now hand it over to Dr. Rakesh Mishra.
Thank you, Mark, for introducing all the panelists, and welcome you all for this first session on wastewater surveillance and other applications of molecular technology in surveillance. So, in the inaugural session, we already touched upon the importance of surveillance in many different contexts. The lessons we have learned during pandemic, it was really important, and very quickly, within few months, the system realized that the surveillance can be done using simple molecular techniques. They are appearing now simple, but for some people have a lot of effort. And that could give us an idea of what is happening and what steps can be taken. If suddenly in some part there is surge of cases, in a couple of days, we could tell whether a new variant has come, or people have been partying, or there's an election rally, or there's a festival or something. So you know that whether it's a human element or virus has come up with a new tricks. And accordingly, then the civic bodies can take necessary steps. And Bangalore have been very, very cooperative in this and being in constant back and forth information exchange, and that has helped both the sides. So this already, even in this kind of emergency situation where there was a lot of shortage of chemicals and communications and many things because everything was very new, still the importance of surveillance has been established and realized by the system. In the we have to have technology, we have to have process by which we can do, and we need support of sampling, then coming to lab, then informing it to the system, and there are so many aspects of this, and that is what we are going to listen from our panelists. They are very distinguished, they have really accomplished in their own domain, and you are going to hear the tale of 3 cities, how this surveillance has been done, and what we have achieved, what difficulties they have faced, and how they manage them. And then in each round, the Indura will then summarize in a national context how you are going to see in the broader picture of surveillance appearing in the incoming future. I just want to emphasize that the surveillance pandemic has shown that if we do it carefully, we can actually do many things very early on. We can even identify signatures, we can identify the bug appearing, and if we know enough of correlations, or we have done enough studies or documented enough, we can even say that the new thing that is emerging, what kind of clinical problem it may raise, or whether it will not be vaccines will not work and so on, those kind of things, because we know how vaccines are made and what new thing is coming. So many things in the future one will be able to tell by sequence information that can be generated. More importantly, we can even trace how the pathogen has evolved and how it has originated. Has it come from Delhi to Nagpur to Hyderabad to here or whichever way, because you can make a phylogenetic tree, and lots of people here, they are experts. Tej from CCMB who's done tremendous work and contributed to how we can trace. And he has been doing it from very early on, when the first eruptions happening in Hyderabad, and we could figure out from where this came from. So if you get enough sampling of sampling of affected places, you can actually reconstruct the history of the virus to very accurate level. You can go back and even tell when the virus has probably originated if you have compiled mutations and rate of mutation of So there are so many things that can be done about understanding and disease and evolution of the virus. So with that background, I will request one by one our panelists. So I'll begin with from that and from Farah to tell about her experience and what message she can give from her experience of doing the surveillance in the city of Bengaluru and nearby places of more recently. So that will be the first round we'll go. And I would request audience to participate. So once the first round is there, please ask your questions. We have 1.5 hours, that's enough time. I don't want this to be just a monologue of only 4 or 5 of us talking, and you can contribute far more. So I would like you to ask questions, and then we will test them.
Thank you. Can you hear me? Okay. So Bangalore, I think it's been easy and difficult at the same time because the scale of the city, it's a huge city, right? We have nearly 13 million people who reside here, but at the same time, we have a fantastic sewage network system. The biggest challenge for us was to make sure we establish this program in real time. And I'll tell you what that means, because I didn't have a team which was trained to do this work. I had to really ask people, I still have all of them sitting in the background who are working on mosquitoes or other stuff, to be trained in doing RT-PCR, trying to understand what that means. This is also at the same time when people are being sick also, right? In Omicron type, I had time when people were literally, I had 10 people in the team down. So there's no limit to people who can have in your team who can run the show. But having said that, just to make sure you collect the sample in real time and also analyze the data beyond the detection level that it is just positive or negative, because we were to sequence those samples as well and interpret the data, what variant, because we just saw the commission. The only question they asked, if you're saying a sample is positive, if you're seeing a spike in your sample, what variant is causing that spike in your sample? Can you tell me that? And I think that's the biggest challenge, I would say. And wastewater data is very, very messy. You cannot just say it's a clinical sample, it's only one variant over the other variant. I think for me, that was the biggest challenge, to assembling a team, to making sure. And I think the only reason we can pull it off because we are in a campus, which is so, I feel so privileged. We work here, we have everything. It's just a matter of making sure you get your act together. But also at the same time, I would say that for a city like Bengaluru, wastewater surveillance is just not about a person who's understanding the virus. And you need an expert in your team who understands your sanitation network as well. I have people like that also in my team who understand how the water flows through the city, because sewage network is basically like an alimentary canal for the city, right? All the sewage is going to these treatment plants where it is getting digested, treated, and then being used treated water for the next level, for agriculture, for groundwater recharging. Imagine having a person who tells you that, and that's how you define your catchment areas, the size of the population for that catchment area. All those factors play an immense role because you are detecting the virus. What does that mean? Can you normalize the data? What's the flow rate of those, treatment plants? This is the science you need. This is the kind of knowledge you need in order to interpret the data, and then only it makes a difference. That hot spotting or figuring out what wards. And I would say having all that kind of resources and people, I mean, with our commissioner, for example, when we went first time, second time, third time, everybody was firefighting, everybody, because this just started after the Delta wave. And nobody has time to listen to someone like me, right? What are you showing me a viral load? But it was a trust building, a slow process. We didn't give up. They didn't give up. They never said no, but they wanted to understand. And we had few sense-taking workshops. How do you interpret this data? What do you mean by this viral load? What do you mean by these variants? And I think that is so encouraging and learning for all of us to understand how this information can be used. So I would say for a large city like ours, I think we had all the good ingredients to pull it off, and that's why we did
it. Thank you for having me on this panel, for telling the story of Gandhinagar, actually, So there's this friend and a collaborator who was working with IIT Gandhinagar, Manish, and when we started, when the first case was detected in India, and then, at that time, we were hosting a Genome India, a very big meeting, which was a GATK workshop. And I think from 30 countries, 30 states, participants had come. And then there were international team from the Broad Institute, and then somebody from IISc just called me. That at that time the fear of COVID was very high, and the COVID was not that dangerous before Delta. Somebody just called me, I will not name the scientist, and he said that there is one fellow in the workshop who has been with a person who was, in a lab working for a week. In that bus, somebody is COVID positive. And at that time, we were tracking all the value chains across. And then I thought, oh my God, this is going to be India's super spreader event. Because I think from every state there was a participant in a closed meeting room, like 30 people, and we were there for morning to evening for full 3 days. So, and then we couldn't do anything. Whatever had to happen had happened, and then fortunately nothing, came out of it because, the indirect contact who was there in the workshop became COVID positive, thankfully. But coming back to serious surveillance, we have only 5-day lockdown in GBRC, and I think many of the people here on the panel, they know we have a very small setup. A one floor of a laboratory there, we have got everything. And in lockdown, there were only 5 to 10 people who were only living in Gandhinagar were there for the use of lab. Rest everybody were sent to their respective homes. We requested everybody, but then everybody said we cannot let strangers stay in any of the organizational facilities. So we were doing clinical samples, we were doing RT-PCRs and everything. And this friend came one day saying that, oh, can you do also CVH surveillance? So I was already working for 18 to 20 hours in lab at that time with, a pressure that you have to give RT-PCR results within 24 hours. Otherwise, you'll be asked why you have delayed those RT-PCR results for clinical samples. So I said my priority is clinical samples. So then he kept on coming, and then I said, okay, first you go and get the samples. If you will get the samples, let me see what I can do about it. So then he was also deep like me, so he went and got the samples from Ahmedabad Municipal Commissioner, and then he said, okay, these are the samples. So I said, okay, I'll do something about it. And then again, almost a week passed, and then he was the one who was pushing me always. So one day I was like damn busy. I said, you brought these samples from Nali, just go and throw it back. But then, somehow he persuaded us so much, and then we were also convinced. Otherwise, I was a hardcore molecular biologist and didn't know anything about environment surveillance. Okay. So then we identified which assays can work because a lot of, we didn't have RT-PCR tests for clinical samples, and if I use them for wastewater, somebody is going to ask me because I have to daily report how many kits I use. So we have to, design a mechanism that with the limited resources being coming to our center, how to, set protocol, and then also because he gave me sample and then he went away. He said, now you give me the results, then I do something about it. And then we established the first, environmental surveillance in Gandhinagar. That was, I think, we could also publish it first. So we started surveying Ahmedabad and Gandhinagar. We were only doing IIT Gandhinagar to begin with. And we did it for around, till today we are doing it. So we started having systematic data from June 2020 onwards. And since then, we have surveyed, initially Ahmedabad in total, and then Gandhinagar, and now state government has asked us to survey all the municipalities. So that's how I think, we could work. And then we also did whole genome sequencing, comparing it with the clinical samples, understanding the variants which are gaining advantage in the community. And that's how, whatever we did is, I think, most of you sitting in the hall know about WB, and I think that was a very eye-opening exercise for myself as a scientist, where I could understand the potential of the wastewater, and now we are continuing it even beyond COVID. So that's it from my side. I will begin with a disclaimer that Pune Knowledge Cluster is not a research institution by itself. I think as Kumar mentioned, we are an enabling organization. And when COVID hit, we were about 6 months old. And we were finding our feet, and existential feet in that sense, in terms of what is it that we are going to do. And like us, 5 other clusters in other parts of the country were also finding their feet. We were very newly established with the mandate of bringing together various organizations in the science and technology space for adding or sort of creating greater community value. Nobody defined that community value for us. It was up to really figure out what that value could be. When COVID hit, and as I said, about 6 months into it, as part of this alliance that we are all part of, Bangalore, Hyderabad, and Pune, and because of the fact that we had Professor Shashidhara who was anchoring this also in Bangalore and Pune, whether Pune Knowledge Cluster can serve as a nodal organization to carry out disease surveillance for COVID. And at that point of time, I think we had a lean staff, very young bunch of people who we were recruiting. And personally, I was not part of PKC when this program started. That means we didn't have somebody helping a leadership role. We just knew that this had to be done, and we knew that an ecosystem broadly existed in Pune. Farah mentioned how this was maybe easier to do because it was a campus and you could bring people together, but we had to actually do this without campus, without infrastructure resources ourselves, but to really depend on what existed already in the city. We were able to put together a consortium of about 10 organizations, all very reputed institutions in Pune. It included CSIR NCL, ISER Pune, a bunch of hospitals, BJ Medical College, Symbiosis, Nobel, very old established organizations in Pune, a bunch of pathology labs, a bunch of startups which have technology to collect samples, and of course our stakeholders, which were our civic bodies. And we carried out both disease or managed disease and genomic surveillance. We managed funds for a funded program. We managed the project itself, and we ensured that whatever resource gaps existed within these organizations, we were able to fill with additional capacity. What this also demonstrated was the fact that certain collaborative ecosystem was possible to create. We really did not, I would say, create a new institution or an organization to make this happen. All we did was build within existing organizations, build capability, whether it was human resources, whether it was infrastructural capabilities, or whether it was even training across institutions was something that we could do. And that, I think, was possible only because of the fact that that was our core mandate. The fact that we could identify gaps within organizations and identify who could fill in those gaps and where to plug in these resources. And what this resulted in was actually a very, economically effective program, because you were not sort of building things from scratch. You were really basically trying to improve what already existed and empower scientists who probably were not doing this all along before, to now do this kind of work. This work still continues in Pune, the consortium that we put together. In fact, there are some representations from that consortium here in this room. I'm very happy to see them here. This continues, and we managed to continue this consortium. And I think post-COVID, 2 things happened. One is a lot of this data was always shared with our civic bodies, but I don't think they completely understood how they can use this data. So a lot of this conversations on how this data can be used by them started honestly post-COVID. And that meant taking this data, converting it into a usable form. When I say usable, it would mean a language in which they can understand this data without a lot of scientific jargon, but with very, very clear, actionable insights on how this data can be used by them. And those conversations still continue. And what this also resulted in was bringing on board organizations which can visualize this data in a very different way. So sort of being this enabling organization also allowed us to really expand our scope, look at organizations even beyond Pune, which can actually crunch this data and look at this data from maybe a governance point of view, a policies point of view, etc.
This machinery that we have built is now being extended to other infectious diseases. So we're looking at dengue, we're looking at AMR in wastewater. A lot of the protocols for this is also shared amongst this consortium that we work. Again, it's a very collaborative approach. And I think if we are able to sustain this machinery in a way, I think this will probably lead to a much more sustainable surveillance mechanism in the city rather than building something ground up. And that is something that we really intend to do. I think we worked very hard to set this up. I think now it is up to us to incentivize the scientists who are involved in this process to continue doing this work, because when they start seeing relevance of data, in terms of how actionable this data becomes, automatically, I think they feel incentivized to also continue this work. So I think that's just an example or a case study, if you may want to call it, from Pune, where with a very lean team and with very, very limited resources, we're actually able to get something done at scale. And hopefully we are able to sustain it because it is built already into the capacity of these institutions. Thank you.
It's a privilege to share the stage with all three of you. Each of the output I have visited and had the interaction with your teams. Quite amazing. In the same context, you are working in building teams and showing leadership. It's quite remarkable that I will get to share this stage here. And I also say this in another context, in that Rakesh wanted me to talk about the national context. We are setting up this national One Health mission. And disease surveillance is one of the most important pillars. And in addition to doing a disease surveillance in the traditional way, what are some things we do that is new, innovative, brings the technology, but influences the decision making in an appropriate way? Where all three of you have had experiments in real life to show. And that has been quite amazing to see, where India was one of the earliest to implement. I was sitting in the US during the first outbreak, and I was asking, why is wastewater surveillance not happening? And these city level experiments in that scale has given me and central government confidence that yes, it should be a big part of our national mission. For that, I'd like to thank you all. And it's also the international level, at the international level. We had a G20 where we started a new track this year under India's presidency, Chief Science Advisory track. All the principal scientific advisory quality in different countries, they call it things. And one of the main topic we started with was One Health, where I'm happy to share we were able to reach consensus, because it's quite a challenge in this context to reach consensus on anything, let alone a complicated vague topic as One Health. And environmental surveillance technology, methodology, building that community of practitioners, disease modeling, all of that were highlighted. So it was not a generic statement that let's all come together and work. It was very specific, and intangibly, these efforts are what gave us at Delhi the confidence that India could take it up at the international level. And it was reciprocated. They really appreciated what is happening in India. Now, for those of you who don't know what is happening with this National One Health Mission, so this is a new mission being set up with participation from across the participating stakeholder departments, whether it is science funding agencies such as DBT, DST, CSIR, ICMR, etc., or ministries with the mandate to implement it, whether it is NCDC and the whole DGHS family, Ministry of Health, Animal Husbandry, Ministry of Economic and Forest, and also entities such as NDMA, the disaster management, want to bring that approach into this, and also the biosecurity angle, because that's two sides of the same coin. And I may end up getting called at any moment because things are at pretty delicate period there to move this through, and then I'll have to apologize if I end up having to do that. But that is maturing. It can only be enabling. National missions are just enabling. Implementation doesn't happen at a national. Implementation happens at state level, district level, and local level. So in that way, it's a bidirectional interaction. What is happening here influences how we are looking at national programs and designs of these missions and so on. And hopefully that also influences back in the sense that we started with COVID, but now we have an opportunity to think it from a broader perspective. What bouquet of human diseases can this fentanyl, which is an aggregate, so why do we care so much about environmental surveillance? We could go sample every individual at every site, but that's too expensive and impractical. Environmental surveillance are these sentinels, are the aggregates, give us a window into what is happening in the broader environment with a much more efficient way of information. That is one. Second, it also gives us something more in terms of what stereotype is emerging, what is the dynamic happening in that compartment. And it also gives us heads up early on before things really look really bad. So that's one thing, expanding it to other sets of diseases, but also expanding it beyond human health. Because in animal health, also there are national programs vaccinating 30 or so crore cattle, buffalo, on foot and mouth disease, brucellosis, PPR, which is a sheep and goat disease, and so on. And there, environmental surveillance is huge value. You may not get what you want just by wastewater. So you'll have to go to other aggregates, milk, where animal trade happens, slaughterhouse effluents, and so on. And beyond that, wildlife sector, where this may essentially be the only serious way you can actually sample that environment, because you can't really sample wild animals in the free range context. You can do that in zoos, or you can do that in the rescue context. You may have to do all of that, so tie it together. So, see, saying this is easier said than done, because we really don't quite know how to link it to the first biggest problem, the most important problem, how you tie it to decision making. Just saying that you have typhoid in your ward, what would Dr. Tilakchandra do? We have to almost think it from his perspective. And that's true when you expand it to other diseases. It doesn't mean we stop when there is no public health decision. Before COVID became COVID pandemic, there was no public health decision. If you were so far ahead, say in 2018, people would ask, why do I care? Right? So it doesn't mean that we stop doing what we are doing, but we hang it to what drives the program. For animal diseases, tying it to foot and mouth disease and brucellosis, where 13,000 and odd crore program, national level vaccination, surveillance, everything is done. Tie it to something very tangible, gives the feedback and real-time action to the decision making in the state. And that allows researchers and others who are pushing the boundary to take up something else. When you collect a sample, you have the sample, you could look at other things and stops. And the other thing, last thing I would say and stop, is what may happen with success is that it's a personal experience when I work with ministries, design programs. You have a lot of control in the design. And then when you co-develop, by necessity, you have to let go of control. Co-development essentially means you develop, which means people hang their ideas onto this Christmas tree and it looks beautiful and more ideas come and it actually makes it better. But from a purely control perspective, from an experiment definition pattern point, it does lose a little bit. When a program matures, what is the definition of a success? It's really good that ministries and departments took it up. Then you really don't have control. That is a process of letting go. And I hope we all get there, right? And I can tell you that is not as easy, because this was idea that we matured as a baby and we know we could do better. But when you take it into public health context, like Anil knows it better than things look, it is not as easy in a public health context. Things are very messy. Lots of forces define it, some good, some outside of your control. And you as a researcher or we as a thinker could have been done better. True, it could definitely have been done better when you have full control, but that is part of the lake. And my hope is success in this is matures to a degree that all of us get so frustrated, which it will happen. But the ideal scenario is that program which was taken up makes public health decision making. I probably should use not public health because I was just pointing out. Public health definition by definition means human health. Human health sector decision making, livestock, animal husbandry decision making, and conservation sector. And they influence each other as well. You do better job in controlling zoonotic, maybe it helps both productivity side as well as human health. Influences those programs better than what they are today and gets them into a continuous improvement cycle. It will never be perfect. If we get to a continuous improvement, we have won. So today is better than yesterday, and tomorrow is slightly better. So, thank you. You are always comes up with a very impressive perspective also, and was very close to the government. What he says is very meaningful, important. So anyway, so we want to, what you just heard is that how when the need arose, emergency came, how these are the examples that you just heard that many places one could repurpose, reassemble the teams and really respond to the challenges for which even most of were not even aware of. Many people who have started doing this, they have not heard, are not handled by it, and but ended up contributing in such a tremendous way. And I consider what Sindhura has said as a success of these institutions that government took note of it, and we are making one institution and policies and those things are being worked out for this. So I think we can be very proud of what these institutions whose job was something else, but when the need rose, they did it. But we should remember that we should not plan to operate in emergency. When emergency comes, it will happen. But planning means you preempt those things. We don't expect research institutions to keep providing service forever. The scientists will divert, they will get more interested in other things. The challenge is now that once it is established that this can be done, this is important, this is urgent to be implemented. How we make it a really the essential component of our civic body, where institutions can keep contributing, analyzing data, helping, understanding the disease ecology, disease biology, but as a service and monitoring the pathogen levels and collecting and sharing, using the data should become part of our routine, normal routine of the civic body. So that will be a challenge, and that's where you can see from the top down there are efforts being made. And I hope that the private sector will get involved and contribute to servicing, providing services and providing consumables. And there are a lot of efforts happening in that direction. So at this moment, I would like audience to ask questions to experts or make comments. You concluded.
Thank you. This is a very inspiring set of comments. I'm coming from the perspective of a clinician involved in public health in India, but also very interested in my health. So, as you know, the idea of looking for viruses in wastewater is not new. The Middle East has been doing it for a very long time, and the Syrian conflict really showed us what happens with poliomyelitis, and we start discovering wild-type poliomyelitis virus in sewage water, wastewater. But there are other things that I think that I'd like to get your perspective on in terms of looking at what happens holistically, not just viruses, not just pathogens, but wastewater is a great way to look for resistance. And let me give you a clinical example. Denmark, which has a beautiful system, analyzed their data and found that those people taking proton pump inhibitors got a whole lot more listeriosis. And I'm, as a clinician, having a lot of trouble making people understand that proton pump inhibitors are not good for you. They do a lot of bad things, but amongst the things that I don't like as an infectious disease clinician is the fact that they increase the expression of extended spectrum beta-lactamases, but also increase the expression of other resistors, increase the expression of virulence factors that influence invasion. So there are a lot of very bad things that happen. Let me ask the audience, how many of you people have ever taken things like PAN, Sompraz, and so on? Raise your hand. No, even periodically. And believe me, one of the practices that I came across when I came to India that was floored me, that all clinicians have this habit of prescribing proton pump inhibitors along with antimicrobials. So I asked them, why are you doing that? Well, the antimicrobials upset the stomach, so that's why we give a proton pump inhibitor along. So I mean, at a scientific level, of course, that's a bizarre explanation, right? But this is some of the other thing that I was interested in. Are you looking at all of the other factors that influence, the lack of, shall we say, our ability to control bad things happening to us? Okay, humans, animals, plants. People are spraying azoles like they're going out of business, and I see a lot of azole-resistant fungal infections in humans. So, your comment.
Comment from the audience. Once you want to comment.
Yeah, I wanted to counter comment on that. Why clinicians do preserves and ismopreserves. I work on clinical surveillance, and I know I've been talking to a lot of doctors. GERD is another pandemic that India will face, and proton pump inhibitors become very many patients, many critically people who need management, disease management, have to take that. But it's a very interesting point, sir, that you raised, that the correlation between ESBL expression and proton pump inhibitor, a very small group in Austria is actually working on it, sir. If that comes out and if we understand the role, I think a great deal of pharmaceutical companies would find it very difficult to survive after it, because it's a big market of PPIs. So yeah, that's a very relevant point, but I don't know how do we connect it with surveillance. That's something which I missed. But my question, other than that, was AMR is again something which as said, there's a tool, right? Is something which we really need to focus on, and clinical surveillance of AMR is not very straightforward. So how are you correlating clinical surveillance of AMR with environmental surveillance? I was just there when you were talking about building the dashboard of AMR, Dr. Mansi. So I would like an input from you as well. Like, what do you think, and how do you draft out a proper clinical AMR data and environmental? What is the correlation there?
So, I mean, surveillance, before Madhuri gets in, surveillance is a very broad thing. As you mentioned, we can actually analyze what kind of drugs people are taking, what kind of nutrients are there, what kind of non-clinical pathogens are around. Because it's really whole Pandora's box. And now there are even indications that you can even assess human genome variation from you. So you are really going to see a revolution that will come out of the wastewater, and it's only how carefully we handle it, because it's going to be very, very sensitive. Imagine you can just tell in this population, these are the people who will be susceptible to this or that, or they are using this drug, and companies can take decisions. So there are many aspects there. So we will focus on infectious disease, which is where there are expertise around. But like mentioned, the scope is tremendous actually, and I'm sure things are going to be. So coming back to AMR, maybe you and then I ask the biology.
So there are two things I'd like to respond to both of you. When you talked about the system and what we can do, beyond maybe COVID, that's what you were trying to, I think, ask out of the wastewater surveillance. So there are two things that I will comment here. One is when the pandemic ended, and we are basically a state government funded institute. So like almost daily we talk to bureaucrats and decision makers and listen to their questions. So we are always asked about why you are doing, what we can gain out of it and all. So state government has now funded a project to GBRC, wherein we are trying to establish a baseline data of 25 sites in Gujarat, not only for infectious diseases, so all bacterial, all fungal, all microeukaryotes, and viral pathogens that can be captured from the sewage for 1 year, at 25 locations. Along with that, we are also going to monitor key pollutants. For example, I mean, everybody knows about microplastics, but what about pesticides and what about, other chemicals that we are using? So what is that is influencing the dynamics of our wastewater? And coming to the infectious domain, what we can do and what we cannot do, so all those things. Coming to AMR, I think that will answer Mansi's question also. So state government has established a network of antimicrobial resistance, superbugs and One Health, where, for the first time, I think any initiative which is funded by state government has stakeholders from clinics. So there are 20 hospitals, all the major government hospitals where the microbiology department is there. They are regularly doing ASTs and other things. They're all sending their cultures to GBRC. Along with that, veterinary hospitals and laboratory, who are looking at infections in animals, they are also sending their cultures. And then we have environmental labs, who are doing surveillance in environment, specifically in the sites where, you have the higher number of factories, Gujarat being, one of the pharmaceutically important hub, the sites. So from there we are getting environmental sample as well as the isolates. So close to 6,000 isolates now we have already banked at GBRC. They're all WHO priority pathogens, and from that we have completed around 1,600 whole genomes. So what we are trying to understand at the end of the day is that how this AMR is moving from one place to another place, what are the factors that are influencing. And I tell you one of the very important things, they're also part of this One Health Poultry Hub, which is funded under GCRF. In that, we conducted a small study. Our focus was to only look at the poultry distribution network and understand that how AMR is transmitting from one area to the other area in the poultry distribution network. In that, we conducted a small experiment because the poultry litter is being used as a manure in agricultural fields. And what are the risks of transmission of AMR from poultry to agricultural field and to the consumers thereafter. And we could see very, very clearly that, the AMR genes and the organisms which are present in the litter are also there in the soil where it is being used, and then also transmitting it up to stems. We didn't go further, in that paper, but now we're also keen and looking at it that whether they are also reaching to the consumers. So in short, mapping the dynamics, how all these things, you can connect the dots at various levels and then try to maybe create a picture that has some value for mankind. So I hope I answered your question.
I'd like to come very
I'll do
quickly
very
before we
quickly.
second round.
Yeah. So we are doing the same thing, but we are looking at the problem in a very different way. If you remember, I just mentioned that you must know somebody who understands the sanitation network of the city. So when you take something in your digestive system, everything gets digested. You have lots of bacteria and everything which helps you to digest, right? And that's where also can be horizontal transfer of genes and everything can happen. Same can happen in the sewage treatment plants as well. You have activated sludge, all kinds of bacteria, fungal, and everything is there. And these are the melting pots actually for the horizontal transfer of genes. Imagine that water, if it is not treated properly and if it is being let out after being treatment, just very minimal, removing some kind of pH coliforms, it's used for agriculture. That's the thing which we are focusing on, that what's the water footprint, because Bangalore has a very large kind of a network where this water is used for agriculture, a lot of drought prone area. So it has both climate and health impact. So if you can change the source where the water is treated, I think you can solve this AMR problem or antimicrobial resistance genes problem at some level, and then you can tackle at a different level what others are doing, like you can look for in the livestock settings or other places, what kind of ARGs are there and what kind of pressures are being faced.
Yeah.
The question is, I mean, when we do the wastewater surveillance and you have the signals, how are we validating these signals into good signals, what sensitivity of these signals, what specificity of these signals? Because ultimately, from an action takers, any signal need to be validated for these things. What is its positive predictive value and negative predictive? So are we undertaking those aspects?
Yes, that is true. I think the wastewater surveillance is just not about that you do that. We have to have all the controls and everything in place, both for extractions, both for the PCR and everything needs to be done in replicate. And I think that's the challenge. So this has been initially when the wastewater surveillance started. I think I saw a lot of labs were doing say only one sample because to also minimize the time and the cost they had, and they had to produce the results. But I think the danger is that when you don't see any virus in the SARS-CoV-2 or any pathogen of interest, that doesn't mean necessarily it's causing there could be kind of a fault in your PCR. So that's why you need to have all those internal controls. So yeah, definitely.
As a public health student, one comment is that it's interesting combination of the panel. Academicians, research organization, knowledge management organization, and policy makers. What is missing is public health. So I'll ask a public health question. By looking at the load in the wastewater, can we correlate it to the infection load in the community? Do we have any data on to support that?
Yes, you can. And actually, this correlation of the COVID cases with the viral load has been done immensely. And actually, it has been very precise, very high correlation. But for the last, I would say 6-7 months, when the testing has gone down, only the wastewater data tells you that number of people could be affected and how the infections are. Thank you.
So I can just add to that comment. A couple of years ago, so we did the same thing in Hyderabad, and we showed that the infection that is being reported is actually 20 times more than what we are saying in clinical practice. And we face a lot of fire and attacks from various things. But after some time, when we did zero surveillance was the exact number. So actually it gives, because at least in COVID case, you can be very accurate because we know how much, and most of the viral setting is to the root, and we know the number and the quality. With STP access, if you have, you can it's very accurate. Maybe not for all the pathogens, but this is the very.
Dr. Para just said that it's difficult to analyze and then interpret it. So are you planning to standardize it so that everybody in the country, use that?
There was mentioned, so as part of this consortium that we have, so Bangalore, Pune, Hyderabad, the 3 cities, while we were rectifying and doing the PCRs, we made sure our protocols are the same and they're very easy to follow. It's published as well, and we were about to release our website, but everything will be made available. It's there. And any lab where you have an RT-PCR machine and you can use it for very easy.
Okay, I have 2 more questions. One is, actionable points. Now, actionable points, you are having data available with you. Do you think there is need for an epidemiologist with you who can, convert this data into the actionable points?
My data every out there.
Okay, no, at your level, I think I don't.
dashboard for so long. We never hit our data, ever.
No, what I'm trying to say that at your lab level, if you have an epidemiologist available working with you, it can make data accessible at that point of time only so that it is.
So we from the collecting the orders, we're analyzing everything, make sure we analyze it, interpret it, and in fact, when we share our results, for example, variant or something with the commissioner or somebody else of public health, you're not just saying that a variant is found, you have to put it in the perspective of say what that means national, international. Like recently, I had a request last Monday, have you 8.86, for example, or all those things you have to be on top of thing and making sure the sequencing is done in time in certain way and you are aware of what's going on. So yeah, all that is shared. One thing I don't do, I will say, I know journalists are there who have been pestering me to tell them what variants I have seen. I don't like to make a public scare of some of the variants because the person who wants to take an action, which is the public health commissioner, they should have access to that. Not publicly, but yeah, viral load and everything, whether the kind of a load spike is going on or it is down, that's not spotting as well of the whole.
Okay, the last question is, do you also have some feedback system from the people who have used your data and give you feedback so that you get encouragement and also for future?
So the main user for me is our municipal corporation because for Bengaluru city they are the one.
Do they give you feedback every time they use your data?
Where would you want?
So our first stakeholder is that data should be given who has given you the sample because they need it the most. Rest everything is secondary, so they can take immediate action. This is what we do wherever we get. If people can come airport, you tell them that this is the variant and now you take care of it. So that's how you get the trust. Otherwise, why did they give you sample? They are so busy? So there are hundreds of questions from politicians. So they give us time, which means they are getting some benefit out of that. And this takes, as far as take time to establish that evidence. And just to reiterate what just said to your first question, that these four cities, Hyderabad, Bangalore, Pune, and now Delhi, are a city cluster program for 3 years funded by Rockefeller Foundation, very generous funding which got all these four clusters together. And one of the main things what you very likely ask is that we should come up with common, robust SOP for how to do this protocol. We share the protocols, and as I mentioned, we are going to have our website which we are available public domain, what protocols we how to sampling, all those standards together. Then only there is meaning in that. And our funders also put pressure that it should be spread. It's not just to do publish and forget about it. So yeah, we are very much responsible.
I just want to add to both Dr. Kumar and Reddy's question. The concern, I mean, we've been continuing surveillance. However, because Farah mentioned, we do have clinical testing going on along with surveillance. More recently, a few weeks ago, a lot of people in Pune fell sick with the flu, but wastewater showed that it was we could actually detect COVID, and some of the peaks that we saw were much bigger than the peaks that we were seeing early. So we didn't have data to correlate with clinical tests. One request that we have had from experts is that if we really have to demonstrate this correlation in a more sustained way, because it's not under our control to get the entire city test, we can only do wastewater surveillance. Can you actually do surveillance in a more controlled setting like a hospital? Because if you are admitted in a hospital, you will get tested. And if you do get tested and you also look at wastewater from the hospital, chances are that you will be able to make better correlation. So I think that is something that we intend to do going further, that we pick a few hospitals where you have large caseloads for certain types of diseases based on where they're located, etc. And you actually do more focused wastewater surveillance so that you can correlate it with clinical. Because we need to come up with some kind of standards to say that if you have, say, for example, beyond this viral load in wastewater, it is a cause for alarm. Below this, it is not. And this is a question that we are repeatedly asked by our civic bodies. Is that, can you give me some idea as to when I should worry, when I should panic, when I should not? And I think that's something that we have to get.
Yeah, I think, yeah, that's
Just last question. Thanks for the insight and experience and realize the on the ground level experience versus the national perspective. But just to understand the sampling strategy of wastewater surveillance, what are the factors that you use to determine the sampling strategy during the height of the pandemic, and how has it changed as we come out of the pandemic? And perhaps a follow-up question, do national surveillance strategies affect the sampling strategy? I ask it because a couple of weeks ago in China, discussing with the Central CDC on their wastewater sampling strategy. And they actually did 24-hour sampling strategy every hour to take one sample for the whole day. And I thought that was for them, they could do it because of resources, etc. But many other countries can't do such strategies. So how much do national surveillance strategies affect on the ground level strategies?
Yeah, I like being there on the panel with
So we're talking about, the sampling frequencies. I think the government of India has set up through DBT, it's an INSACOP, which I think was also mentored by NCDC and MOAF, and it's a joint initiative. Now they also have a component of seabed surveillance, and we are a part of that as well. So initially, we were only doing it on a weekly basis at every, sites that have been identified, And we try to minimize the factors because there are a lot of variables already in wastewater. Okay, the type of treatment, the type of seeded systems from city to city, all the networks and everything is very different. Population dynamics are also very different. So we just try to reduce all the variables so that there is, some data which is consistently being repeated at every site, so that you have a benchmark of X site today and a week after, and a week after, like that. So like what we do here is we have pitched every Monday, morning 10 a.m. is the time where, we collect the samples invariably from all the sites. And that is how when you compare it, then you have some data which makes sense. If you just say today do it in the morning, next week you do it in the evening, then the dynamics will change a lot. So that is one thing. Second thing is you also mentioned about the frequency. Okay. So actually, when there are no clinical cases, you should have a higher frequency of sampling in sewage for multiple reasons as to see that whether is there any, subclinical infection going on, or is there any new variant being, gaining advantage in the population? Why I tell you, if you look at the India story, we saw this data wave from 1st March onwards, it started rising, and then after the end of June, it came down, We had 8 February sample collected from Ahmedabad, in which the whole genome sequencing showed 57% frequency of delta, which means that early in February, it was already there, not at the clinical level, but at a population level. And if you are able to capture such information through seeded surveillance, I think they are of a very, very important use on the public health side, So then in SACOP, when there is no infection, then the sampling goes to maybe twice in a week, like that, So then you have a much closer zooming information on what is happening in community.
Okay, so when we started doing this work, we have 28 treatment plants, and Bangalore is a very huge city. So we really have to come up with a plan that we must sample each treatment plant at least once a week. And to make sure that it took us a couple of months to figure out the whole plan, because as just how he mentioned, because they start releasing the water something like 10 in the morning, you want to make sure you are there in time. It's just impossible, by the way. It doesn't work. So then we started talking to the sewage treatment plant people as well. Can you collect the water for us in these bottles? So we left the bottles, and they all have some small lab kind of system where they can do that. And so it's been a gradual learning process, and they started doing that. So we were very curious to know that while we are going through this pandemic and everywhere you have so many positives going on, if we were to scale down our sampling from say 28 to say half or even 10 of the sewage treatment plants, what could be those bellwether treatment plants can be? Because surveillance is very expensive, and this is something we really wanted to test and try. So we decided, let's take 14 treated plants, which is like half of them. How about you sample them twice a week? And they should be of different sizes, catchment areas. We've done that for about 2 years now, and we analyze the data and we see it doesn't make any change, whether you do it once or twice a week, sorry. So we now doing everything once a basically. So weekly sampling and everything works, and the time of the day doesn't really matter as long as we are there anytime between 10 to 2 afternoon.
Just to add to the story of STP, half of India is only open drainage, and you have a very different strategy for that. And that Hyderabad guys, hourly sampling for several times and saying when you get the best, and so they figured out what is the time which works better, because hourly you cannot do this with practical things. Morning hours, sometime if you do something that is much better and also, and similarly for the water bodies that are connected to cities. So you have to have different strategies because we are very heterogeneous system all yes.
So before we there was a open drain sampling as well. The trend you see in this STP from that data and what we saw in the open drain, it matches perfectly.
Yes.
Okay, please just to be
So most of the work, it's fantastic what you've been doing. Most of the work has been related or with regard to the exposure side, right? I mean, we talk of simple epidemiology in the basic term here, the exposure outcome. Even I'm asking, is there a plan or are there already something for analyzing the data in terms of outcomes? So you have these exposures. So in terms of how well they are correlated with the clinical aspect, what's happening with patient. Something which Dr. Anil and Dr. Sanjeev was also kind of relating to. And a good analogy for this would be we have these air pollution studies, which are ecological studies. Basically, this is another kind of ecological data you have it. You have air pollution data on the one hand, you have population level data in terms of exposure and outcomes, and you have these techniques. So is there something in plan or you already doing?
Something that we are trying to do with dengue now is on those lines. So because of the fact that it is a disease that occurs in certain, or rather you see peaks of the disease in certain times of the year, then there might be a correlation with climate. We still don't know. We just know this empirically because you have reports of disease coming out, say pre-monsoon, during monsoon kind of thing. So we are working to understand how you can layer different types of data that can even include migration and mobility data of people moving from one place to another, along with the disease data itself, along with environmental surveillance data for the disease and climate data to see if we can come up with correlations to predict hotspots for the disease. But yes, that is something that will happen.
So
You can read out?
Yeah. Sure, I can read out. Hi, I'm Anita from Chisti, Indonesia, and my question is, how do you collect the data from community-based surveillance, and what community do you support for the surveillance system?
So, hi, Anita, and so basically what happens is, that wastewater is the health of the entire community. So when we are collecting the wastewater data, it is based on the catchment that, you define that this STP or this pumping station or this ETP has this catchment area. Sometimes, you have an institute, for example, like IITs, who are a small town in themselves, and they are very controlled, areas. So when you sample them, then you will actually get to know about what your data means and how you can extrapolate that data to maybe say an entire IIT by just sampling a couple of sites in IIT. So that's one thing. Getting about, the clinical data, I think what she also means by having a community data is that you have to closely work with the public health system to get, the authentic number of active cases. Otherwise, you will not have, for example, even if you want to work on dengue, just by doing sewage will not give you any leads unless and until you don't know how many dengue cases were there in those areas. So that is where, through authorities, directly community doesn't give you any sorts of data, but through authorities, we get a data that can be used for surveillance.
Thank you, Matthew. The next question is, what and how medical college work in establishing a surveillance system at district level?
So what we have observed is that they play a very, very integral role because holistic surveillance is only possible in a hospital setting comprehensive. They have clinical, they will have water to be able to test, they will have other environmental parameters to be tested. For example, if you're doing AMR, even surfaces and other things in hospitals can be tested. And most importantly, they have capacity. Whether it is students, whether it is public health officials, whether it is doctors, etc. It is that one nodal center where all this information can actually come together. And I think to top it all, they also know about how they prescribe drugs. In the sense, they have accountability for how medications are prescribed, especially when you talk about antibiotics for EMR. So what we work with over 6 such hospitals, and 2 of them are anchored with the Pune Municipal Corporation and the Pimpri-Chinchwad Municipal Corporation, which are our 2 biggest corporations. And what we are trying to do now is actually help them strengthen their capacity for surveillance. Because if we want to sustain this, I think we believe that it will sustain in hospital settings, or the chances of it sustaining in hospital settings is far higher than it sustaining outside of hospital settings. So it's very, very important to build this capacity. We work with BJ Medical College, which is a very big college associated with the PMC, and we are actually helping them set up a facility for sequencing, for genomic testing, etc., so that this can be anchored within a college setting or a medical college setting, hospital setting, anchored to the civic body.
So I request any other online participants who would like to have any questions, please do put it in the chat. And I have a question, which is, how do you look at migration? There are trucker populations, there are people who actually keep migrating on an everyday basis. How does that account for any of the surveillance systems? And how is that layered on what you want to do?
It's something that we are trying to do. We don't know, in fact, whether that would actually have a correlation at this stage. It is something that we are experimenting with. A lot of the civic bodies do have both city level, district level, and state level mobility data. The data can be tracked in different ways, but then the data is available, the data is digitized, and that data is accessible. So we do have first level of that kind of data. Whether it is within a city, it will tell you about bus movement, it will tell you about passenger load, it will tell you about who boards from where to get off where. It will also tell you about what demography those people essentially come from. So we have access to this data. Nobody has actually looked at this data in the context of disease. So the point is to start from there and then see what kind of data we lack, and then go back to authorities and say, if we can also collect these types of data, then it would be very useful. But the data exists, and it actually exists in a very organized way. Thank you.
Questions to Dr. Priya. So, could you little elaborate on what are the actions taken by civic bodies on surveillance data? So, exact actions, like what are they? Could you just little elaborate?
Right. So, I would like to say here that these have been actions that have taken not only based on sewage surveillance data, we have been actions taken by even looking at other types of data that has come with it. So, if I have to take the example of COVID, it's also a crisis situation. They were getting inputs from various organizations, partners, including themselves, in terms of the data. One specific instance that I can tell you about is plans for lockdown. So there was some evidence initially to suggest that a lot of the load started closer to locations that were near the airport. Now, because of the fact that we never had testing data to correlate with this, if you were to just look at wastewater data, you can tell that there was a pattern to how the disease actually spread within the city. And based on that, I think we could do some kind of base modeling to tell them that, okay, I think we sampled about 56 Prabhat. That is how, the data was relevant for 56 Prabhas, and the idea was to essentially tell them that if you have to release lockdowns, or if you have to plan more stringent lockdowns, you should be looking at these Prabhas over these. So prioritizing which area to be, to control was one of the decisions that were made using this data, but again, I would say it was not data, it was looking at a bunch of other data also. But this data did play a role because this data was shared with them on a weekly basis. They would see this data, and there was a lot of communication back and forth with them to say, okay, how do we act on this?
Just follow up on that. How about vaccination? I think this surveillance also sort of sets the tone for how to vaccinate. Did it matter? Like, was the data used for vaccination?
Vaccination, everybody should be vaccinated.
Respond to that based on our experience of polio. Wastewater surveillance has been going on for polio, and we have not reported, fortunately, any case of polio since 2011, within 12 years of success in India. But wastewater monitoring is going on. Some of you will remember in Hyderabad, there was virus detected in wastewater, and there was a lot of action taken by state government and at national level. You can pick up whether the virus is vaccine virus or wild virus. And type 3 virus of polio can mutate and can become a wild virus. So that you can pick up from wastewater surveillance. We didn't talk about polio. We have much longer experience of wastewater surveillance in polio.
Based on the wastewater data, am I correct?
Yeah, I won't be able to comment on that. We need to learn more on that.
I think it's a pretty sharp experiment, and I don't think it has led to that level of maturity, but it very much should be. That's the cycle of prevention, the surveillance, prevention strategy, surveillance, outbreak response, control, all of that cycle. And for not just for human disease, for animal disease. So for foot and mouth disease, it's a prevalent vaccine given all over the country. And you have imperfect information on outbreak because reporting is the only source of information. So this would tremendously help in understanding where is the problem and deploying the vaccination, targeting that, but also be able to say how the 3 serotypes are behaving, so that you have a much more fine-tuned information on is one disappearing. If one is disappearing, if you are the manufacturer, you need lead time. You can't just turn it around and start manufacturing bivalent tomorrow and have enough stock. So this cycle, somebody mentioned industry. So these are the cycles of information sharing and shared decision we need to make.
Sorry, the online participant. Okay, sorry. So maybe in a country like US, where you see that there is an annual flu vaccination going on, and then they are looking at, types of flu or subtypes or serotypes to decide on through sewage that which variant should go this time in the vaccination. So that's how it can influence. Maybe, maybe for dengue, when we know the serotype this year, then maybe if we have a vaccine in future, then we can have strategies based on wastewater.
I can see Arindam has a question. And Mr. Mohammed, please write an email to us and we'll help you set up whatever we know in terms of how low resource setting you can do the best on wastewater surveillance with molecular technologies. It's a whole classroom conversation that we need to have. So let's have that. Please do share your details with us on an email. And the last question for you, Arindam, and then we have closing remarks.
Oh, okay. So it's not a question, just continue on the polio theme as it is much more mature surveillance going on for decades. So if you even detect, say, wild virus or vaccine-derived polio virus, you do a response vaccination. I mean, in that locality, depending on, of course, you also search for clinical cases in clustering. So environmental surveillance in case of, I mean, role of environmental surveillance depends on the objective of your surveillance. In case of polio, it adds to the certification and maintenance of the polio-free status. That's how. Just adding on to that on your migration question. So I think genomic surveillance can have that footprint. I mean, your dendrogram analysis can show you how much it has evolved and what's the nearest, I mean, relative of it. When and where did you identify that? So even without having, and which is very good if you have a city level migration data, which you can correlate. But even in absence of that, your dendrogram can point to the source of possible infection and the branching out. And if your clinical surveillance is mature enough, if you are capturing even the travel history or referral history, because I mean, the occurrence of a health event is a random thing, but the drainage of those health events is a cluster event. So if you are identifying it in a particular geography or particular facility, but where it spent its maximum incubation period or where it actually caught the infection, that's the epidemiology question here. For every disease, the answer will be different. So best, I mean, if you can have multiple data sets and you can triangulate, but I think genomic. There is an interesting case also for very transient migration events. Say, for example, large conglomeration, say festivals. So Shachit Balsari's group, they did a fine, I mean, analysis of Kumbh Mela congregation and how infectious disease spreads. So I think there are ways and means, even in these countries happened without, I mean, we are now exploring newer frontiers, but I'm saying there are other relations as well. Thank you.
Thank you, Anil. I hand it back to.
Yeah, now your turn is coming now. I'll ask the panelists to make the response quickly and make your how you wish good further and let go country. Very quickly,
yes. Okay. Very quickly, I just want to respond to your thing about. So wastewater surveillance is just not about, you go and collect the water. The hot spotting is very important. I think for polio, that was the whole thing, right? Identifying where this virus is coming. And that's how vaccination. Which in case of COVID, vaccine doesn't help, but it still helps. Where there are a lot of infected, what number of people are not in fact kind of vaccinated, can you strategize with it? So it works the other way. Going back to the number of events causing the infection, at a city level, I know it's very difficult. We have tried to correlate our data with Diwali and kind of air shows and whatnot. Can I tell you, this building where you're sitting, we have a fantastic waste treatment plant. Whenever we had a big conference or something happening, we saw signal goes up. No, it does. And we've been doing it since our thing. Now, my vision for the environmental surveillance, whether it's for COVID or for anything, I definitely want to do it for animal sector, avian flu. That's something my dream. But one of the things I think for making it a sustainable thing, I think it has to be integrated as part of the public healthcare system. My vision would be that the way we have the commissioner today, they can say, as part of the One Health Cell, can we have a budget for it where you can do it and integrate it, and you do it for Bangalore City? That will be the vision.
I think that's a very valid question, and I think last 2 months before I spoke here, in the opposite auditorium, how do we take wastewater surveillance beyond COVID, And we have been doing it, as a world for 72 years now for influenza and for polio for a few decades in India. But I think COVID was the one that made us realize the importance of wastewater. People started, nobody was even ready to listen, but the moment they saw that, okay, we can give you 2 weeks lead time, and people had just, passed through the Delta wave, and then everybody was ready to listen to you. Even today, when we go to Chief Minister's office, because he's having a steering committee on COVID, every whenever there is a new variant reported. So we are the only center who does human, environment, everything, in true sense one is, because we don't have any other center to do that work. So wherever we go, they would ask, what's the trend in wastewater? So I think now is the very right time where the policymakers are sensitized enough about what fruits they can harvest from such wastewater-based surveillance to maybe, take it as a regular pan-India program where, we have a good pilot done in a couple of cities followed by identifying location-specific diseases. For example, in Gujarat, we have CCHN. So can we pick it up through wastewater surveillance? I mean, these are the type of things, if we are able to do it for our state, I think that will be my dream come true, and as Titura rightly said, letting it go and let the public health people do it, maybe at a PHC, CSC level, that's where, I think we should aim for the WB survey.
I think agreeing to both my colleagues here, I feel that I think we use a lot of factors to make decisions on the diseases, and I think wastewater should be considered as integral of as those factors also. It should not be viewed as something that is standalone, which we can integrate if we want. It has to be something that we do integrate when we make decisions on public health decisions. And for that to happen, it has to be recognized seriously by the state as a method of surveillance. There has to be dedicated funding, and there also has to be dedicated channels to share that information with the right kind of people so that decisions are made in a timely manner. I also think that there has to be, sustainable measures for wastewater surveillance. And how do you build this so that it's sustained? It can't be something that comes up during a pandemic. It has to be something that happens, routinely and not just for the diseases that we have been doing over many years. It has to be something that we can use to pick up new diseases also, which means there has to be an element of research, which means the data that gets generated has to be shared with researchers. So there has the way, it's not just about doing the surveillance. Now we have a golden opportunity to curate the data that we are collecting from wastewater surveillance, make it open, make it shareable with researchers for them to actually do more work on this so that it becomes something that sustains as a community and not something that just happens one-off by a company.
Thank you. Now, Sidura will tell how all these things come through.
We have actually coined a new discipline today, aviation ecology. No, no. You do read in the news, people behaving somewhat irrationally at high altitude. No, I don't know.
I don't need the high altitudes to behave irrationally.
No, that is relative, right? So this is, I don't know about all of you, but I tend to cry more watching movies at 36,000 feet. I don't know if that happens to any of you. Then I wanted that it does affect your hormonal status. But
That's a big one,
that changes your mood, etc. But closer to the home status, airports are an amazing center. And I have been preaching to everybody I can and my colleagues that and for a long time I thought this is a missed effort. I'm talking about for a year. But now I have seen data, which I can share here, where it has been done. It is immensely powerful technology. And it gives you such resolution that, so the aviation ecology may be a real thing in this. In terms of, we have had wonderful conversation on this. So we are on the right track, I feel, and right track of both validation, method development. There is tremendous amount of work being done and to be done, and expanding it to other spheres. And for me, I have a scientific background, but I work in policy. So with scientists, I bring the policy side of things, and for my policymakers, I take the scientific side of things. So they both get frustrated with. So that is my job. My dream probably is, newspaper, you have all this news of the day. Maybe one day we will have a column. What's fresh from the wastewater surveillance today? it becomes a real thing. But the ideal outcome would be that it becomes a routine program that integrates information with rest of the disease surveillance approach and control, whatever that is.
My harvesting benefits from wastewater.
Antibiotic. Yes, we can do that.
No, fantastic. I think that's the best conclusion. So I'll not dilute any further. And thank all my panelists for the wonderful discussion and the audience for participating. Thank you all very much.
Thank you very much. I always provide the entertainment in case you don't miss it. So, yeah. So, I believe that we are already at the end of the first day session. But having said that, I am scared. Should I drink water? Should I eat food? What should I do next? And how is it going to be? How the wastewater surveyor is going to tell me what is going to happen to me next? As a public person, as a lay person, it is going to be something that we'll have to learn to live with. And what ecology is doing to us, what climate is doing to us, what antimicrobial resistance is doing to us, is not something that we can ignore. It's right there at the forefront of everything that we do today. And the fact that we recognize it, and we have so many of us discussing it here this afternoon, evening, and over the next day. Tomorrow at 9:30 a.m. sharp, we will come back, okay? But before that, there are some good times to come. One, there is a tour of the TIGS facility available for those people who would like to take it up. Pankaj, please stand up and be recognized. If there is one group or two groups, there are people who will be able to take you around that. And second thing is, while you network in the atrium, there is dinner and cocktails being set up at the NCBS first floor canteen, which is not where you were this afternoon. There is another. There are volunteers who will take you there. And we will see you for cocktails at dinner. Maybe another hour and a half. We'll start early, 6:30. Please remember, 9:30 a.m. tomorrow morning. We will see you all back here, bright and early, and more on surveillance and building back better.
When the tour is
As we get off this thing. So, all good things need a little bit of a token of appreciation for all the effort that has been made. Tina, Dr. Rakesh, I'd like you to share it with the panelists. Dr. Farah. Dr. Madhvi Joshi. Yeah. Dr. Reddy, can I request you to hand it over to Dr. Until we all have you stand up for the photograph. Dr. Reddy.
You can smile.
Photograph is not.
It hurts.
So the TIGS tour, the conversations in the atrium, and the dinner at the NCBS canteen on the first floor. All of you, please do join us today.